Welcome students, good afternoon. Last day we are talking of cardiovascular system examination, and we have done a video and the word how to examine a cardiovascular system and how to take history from the patients, and that is live. But before going to that, you need to know how the cardiovascular system is being examined. What is the pro forma or scheme of examination? That I have not given in that lecture, just I have narrated how to examine. So today you would note this, how to examine the cardiovascular system. As in other systems also, you know, in my last lecture we have discussed about general examination and history taking, and if you go through this general examination and history taking, you will find that in history taking there are some common points, that is the identification of the patient, and second is the chief complaints 1, 2, 3, then dilatation or elaboration of the chief complaints in the history taking in 3 or 4 para, as you know, then past illness, history of past illness, then family history, personal history, drug history, and in case of female menstrual history, all these things. And in case of cardiovascular system, the same scheme of history taking will remain. 1 or 2 points of past history or like that may be changed. As for instance, if a patient of cardiovascular system, we have to take the history of rheumatic fever in the past, we have to take the history of diabetic hypertension, dyslipidemia, like this in the family history also. So 1 or 2 points, but these are the fixed, and the general survey or general examination is also fixed. But whenever you are coming to examine a cardiovascular patient, you have to give stress on the 2 general examinations. One is pulse, other is the neck vessels. And today I will narrate the scheme of this general scheme of the examination of the cardiovascular system. That is the pro forma. Just you note down it, and whenever we will show you the cases, we will show how to examine the pulse, how to examine the neck vessels, like that. So pulse, it should be examined in the following heading. Number 1 is rate. What is the rate of the pulse? Whether it is in the normal range or not. If it is more than 100, we call it tachycardia. If it is less than 60, we call it bradycardia. Then rhythm, it is regular or irregular. It is regular, it is okay. If it is irregular, whether it is regularly irregular or it is irregularly irregular. In irregularly irregular rhythm, most likely to be atrial fibrillation. Regularly irregular may be ectopics or some heart blocks, like this. Then what is the character of the pulse? This is very important. There are some special characters of some of the pulses. Particularly, you know, it is very popular, water hammer pulse. If there is a systolic pressure is increased and the diastolic pressure is decreased, we call it pulse pressure. In such conditions, if you raise the hand while palpating, the pulse volume will be increased suddenly. That is called a water hammer pulse. The characteristically found in aortic regurgitation. Similarly, there are other characteristic pulse also. Then arterial wall, sometimes we want to feel whether atherosclerosis is present or not. And then other pulses, comparison of the other pulses, very important, particularly if there is any radiofemoral delay or like that. There is a condition where there is coarctation of the aorta, there is kinking of the aorta after in the abdominal region, and there is reduced blood goes to this. There is a kinking, there is a narrowing. So this is a congenital. This is called coarctation of the aorta. So you will get pulse in the radial pulse is okay, but the peripheral pulse, particularly in dorsal spadius or femoral pulse, will be delayed. So there is a radiofemoral delay, or there may be absent of the pulses. So in this way we can diagnose some conditions also. So comparison with other pulses. Similarly, another condition is the arch of the aorta. There may be some inflammation, aortoarteritis, and some of the pulses may be absent. Radial pulse may be absent in one hand, but other hand it is okay. So it is called aortoarteritis. Aortoarteritis. So these are vascular condition. So these are the. So we have to see whether rate, rhythm, character, arterial wall, and other pulses comparison, and any radiofemoral delay alert. Then the neck vessels. It is very, very important to examine the neck vessels. There are certain procedures in examination of the neck vessels, particularly to see the jugular venous pressure. We have to lie the patient in 45-degree angle, and we have to see from the right side and good light, and we have to see the venous pulsation and the arterial pulsation. The venous pulsation may be A wave, C wave, V wave positive, and there may be X and Y descent. It should be this how to differentiate between the venous pulse and the arterial pulse. Arterial pulse is a jerky, venous pulse is a wavy. Arterial pulse is one stroke outway, venous pulse is two stroke, like this sinus. If you compress the neck, there will be diminution in the venous pulse, arterial pulse will remain. So we have to differentiate that this is arterial, this is venous pulse. We see actually the internal jugular vein, but sometimes it is under the sternocleidomastoid muscles, and sometimes we see also in external jugular veins, but it is a sinuous, tortuous, sometimes it is distended due to compression. So it is not the perfect to see external jugular veins, but always we have to find out the internal jugular vein, and we have to find out the upper limit of the pulsation, and then we have to measure this. From this level we have to draw a line, and we know the sternum and then GP sternum, the sternal angle here, it is 4 centimeter or 5 centimeter above the right atrium. So from where how much it is, this way we can calculate the jugular venous pressure. So JVP may be raised in some other conditions, particularly if there is overhydration, if there is heart failure, right heart failure, if there is a constrictive pericarditis like this condition. It may be non-pulsatile also in the superior mediastinal syndrome or like that. So jugular venous pressure and waveforms, that should be looked into in a very meticulous way. Then sometimes you have to do some hepatojugular reflux. If you give a pressure over the liver, and that will transmit it to the jugular vein. So normally the jugular vein is not distended, but giving a pressure over the liver, the jugular vein is distended. That is called hepatojugular reflux. It may be sometimes found in early heart failure. And this carotid artery pulsation, as I have mentioned, is a jerky pulsation, and it is internal to the sternomastoid muscle. Next examination is the precordium. So after examination of the pulse and neck vessels, we will go for examination of the precordium. So as for every examination, there will be inspection, palpation, but percussion is not exempted here in heart diseases, cardiovascular system, except in pericardial effusion. Then auscultation. So on inspection, what we see, or see whether there is any bulging, any depression, any scar marks like that. So there will be different types of chest deformity, pigeon-shaped chest or depression chest, pectum excavatum, pectum carinatum like this, kyphosis, scoliosis, like this sort of skeletal deformities that can be detected on inspection. And we have to look into any scar marks present. If a patient has got operation, there may be some sternal scar marks for sternal dissection and for doing operation, particularly CABG or other operation. Previously, there was a scar mark over the intercostals for mitral valvotomy or like that. So, if there is such scar marks, we may find whether patient has undergone any operation or not. So, any scar mark, depression, bulging. Then pulsation, any pulsation. This pulsation may be in different areas. If this is the if this is chest, this is the area of the heart. So, this is the dimple, this is the apex beat. So, pulsation in the apex, pulsation in the epigastric area, suprasternal area, all these areas were to look whether pulsation is present or not. So, apical impulse is the definite pulsation over the apex of the heart. This is very important, and we have to note where is the apical impulse. So, it is a mid-clavicular line, and from the mid-clavicular line, and this is the we have to count the ribs from the second intercostal space, third, fourth, fifth, inside the nipple. This is the ideal position of the apex. So, whether the apical impulse is present here or outside, that is important. Then we have to see left parasternal pulsation here in the side, left parasternal pulsation, and over aortic area, over the pulmonary area. So, they are the areas, the second intercostal space close to the sternum. On the left side is the pulmonary area, on the right side the aortic area, and all these areas we have to look whether there is pulsation or not. Then over the root of the neck and over the epigastric region I have mentioned. So, one is deformity, then number 2 is pulsation. Then any venous prominence is present. As I was mentioning, if there is superior mediastinal syndrome, there may be tortuous veins over the chest. So, that can give you the clue to the diagnosis probably, and with a non-pulsatile jugular venous pulse, jugular vein, the diagnosis is superior mediastinal syndrome like that. So, venous prominence to be looked into. So, on inspection, bulging, depression, scar mark, pulsation, then venous prominence. Then comes the palpation. This is very important. We have to locate the apex beat, where the apex beat is, and we have to find out in the mid-clavicular level in which intercostal space, outside or inside or on this position like this. So, we just place our hand over the chest. I have shown in a video, then see where there is pulsation, or we can find place 3 or 4 fingers and we have to locate the exact definite pulsation over the apex, and then we have to count the ribs, intercostal spaces, which intercostal space it is, or on the mid-clavicular line, outside the mid-clavicular line, or where it is. So, in this way we find out the apex beat position. Then we find out the character of the apex beat. Sometimes the apex cannot be felt by just palpation. It may be in a thick chest wall or in under behind the rib, it may not be found. So, in that situation you have to turn the patient to the left lateral position and find out the apex, and then turn the patient to the normal position and note the apex beat. Then what is the character of the apex beat? Whether it is normally impulse is present or it is forceful. If it is forceful, if it is well sustained or ill sustained, that will give some of the pathological conditions of the heart, or whether it is tapping, just there is an apex beat which is coming and tapping, particularly characteristic in mitral stenosis. So, character of the apex beat is very, very important, and this should be learned by practice, by seeing patients again and again in the ward. Then we have to place our hand like this in the left parasternal region, and we have to see whether there is heave or not. to see the right ventricular or left ventricular hypertrophy. So, left parasternal hip. Then we have to place our hand over the pulmonary area like this to find out the diastolic shock that is palpable P2. Second heart sound may be palpable sometimes. We call it diastolic shock. And during this palpation, we may sometimes find out some sensation over under the palm. That is just like if you keep your hand over a cat on your lap, there is some sort of sensation under your palm. This sort of sensation we call it a thrill. This is a representation of a murmur, palpable murmur. This is called thrill. So, where it is present, whether in the mitral area, whether tricuspid area, aortic area or pulmonary area, and whether it is systolic, diastolic or containing both systole and diastole, that is continuous, this is important. So, on palpation we will find to apex beat its position, its character. Then you will see left parasternal hip, then diastolic shock is present or not, palpable P2. Then we can place our hand over the aortic area, mitral area, pulmonary area to see any thrill or which is on auscultation we will find it as murmur. Then percussion is exempted usually except in strong doubt of pericardial effusion. So, I am escaping this murmur percussion point here. Now, the auscultation is very, very important. Auscultation is an art. What to auscultate, we know some methods of auscultation, how to auscultate. It should be placed in a quiet room and concentration to be given, stethos to be of adequate size, and the bell of the stethoscope, the diaphragm of the stethoscope, how to regulate that is to be learned. And by listening, you will be an expert of auscultation, and you have to know the character of the murmurs and the different heart sounds. So, first of all, you will concentrate over the heart sound. First heart sound, second heart sound. We call it lub, droop. So, first heart sound is wide and second heart sound is sharp. Lub, droop, lub, droop. If you draw this here, this is the first heart sound, this is the second heart sound. Second heart sound has got two components, A2, P2. First heart sound has got two components, but it is not hard like this. So, first heart sound is formed due to closure of the tricuspid valves, and second heart sound is due to the closure of the aortic and pulmonary valves. This is the portion we call it systole, and this is diastole. So, diastole is greater than systole. So, we have to concentrate in particular area. Say for instance, mitral area, we have to first concentrate the heart sounds, lub, doop, lub, doop. Sometimes it is very difficult whether it is lub or doop. So, you can place your left finger over the carotid, and if it is coincides with this carotid, the first heart sound. So, lub, then there is a gap, then droop. This second heart sound is sharp, and there is some droop, that means some splitting, and this split may be variable. So, lub, droop, first heart sound, second heart sound, then second there is a diastole, then again first heart sound. Similarly, if there is any other sound, that should be noted. Whenever you have learned how to listen to the first heart sound and second heart sound, then you concentrate on other sounds, any other sounds. Sometimes S3 may be heard in certain conditions, heart failure. Lub, dub, dus, lub, dub, dus. This will be the sound. Lub, dub, dus, or dums. So, after second heart sound, there will be a soft heart sound, that is third heart sound. So, it is found in left ventricular failure like that. Sometimes fourth heart sound may be heard in children just prior to the first heart sound. So, you should not, as a beginner, you just concentrate over the first heart sound and second heart sound and find out any added sound. What is the added sound? particularly in mitral stenosis, you may have an added sound. We call it opening snap. This is first heart sound, the second heart sound, and there will be another sound after the second heart sound. It is called opening snap. So first heart sound, second heart sound, and opening snap. Then there is a murmur. It's called mid-diastolic murmur. That is the auscultatory findings of mitral stenosis. And there may be some mid-systolic clicks in the aortic region also, sometimes added sound. It is given in very details here. Sometimes if the patient has got some prosthetic valve, so prosthetic sounds, that is metallic sound, may be heard. Then pericardial knock on other sounds, that is other sounds. But then we have to listen to the murmurs. We have to find out what type of murmur it is. It is a systolic or diastolic. If it is systolic, then how long it is systolic? This is the first heart sound, this is the second heart sound, so this is systole. So if it contains the whole of the systole, this type of murmur, so this is called pansystolic, the whole systolic. This is pansystolic murmur. Or it may be like this, like a diamond-shaped murmur, ejection systolic murmur. This is classically found in aortic stenosis. So pansystolic murmur is found in mitral regurgitation. So ejection systolic, pansystolic, there may be some pre-systolic or late systolic also, or mid-systolic with a click and mitral valve prolapse like that. But you know these two, whether it is a ejection systolic murmur, mid-systolic, or it is a pansystolic murmur. Then if you put your stethoscope over the tricuspid area, then here also you have to hear the sounds, first sound, second hand sound, and added sound like this. All the areas, pulmonary areas, aortic areas, and in the pulmonary and aortic area, you have to concentrate over the second heart sound. Whether the aortic component or pulmonary component is more prominent like this, A2 and P2. So if P2 is more prominent, accentuated, so this is pulmonary hypertension. If A2 is accentuated, then it is aortic systemic hypertension. So by putting your stethoscope over the pulmonary area and aortic area, you have to see and you have to concentrate over these components of the second heart sound. This is very, very important, and it is a good listener will find out whether pulmonary hypertension present or not. One point is pulmonary hypertension, P2 accentuation, it is localized. So if you place the stethoscope over the aortic area, other areas, you will not hear this accentuated P2, but accentuated P2 can be heard of all these areas. In this way, sometimes you may have a guess whether it is A2 accentuated or P2 accentuated. Then you have to find out what is the gap between these two. So there is a gap between A2 and P2. Normally the gap is variable. In inspection, in inspiration, the gap widens and the expiration gap closes. So it is variable during inspiration and expiration. So ask the patient to take a deep breath and see whether the gap is increased, and after expiration whether it decreased. So if it is variable, but sometimes it may happen the gap is not variable. Both in inspiration and expiration there is a wide gap. We call it a fixed wide gap. It is found in ASD, atrial septal defect. So this is very, very important auscultatory finding. So split second heart sound with a fixed wide gap. So we call it ASD, atrial septal defect. So similarly, whether it is single sound or the split may be on the other side also, there may be reverse split. So P2 is coming earlier than A2. So if it so happens A2 is due to the closure of the aortic valve. So if it is a long systolic contraction of the left ventricle, so there will be time of the A2 to close later. So in that situation P2 comes earlier and then comes A2. This is called reverse splitting. It is found in severe left ventricular hypertrophy and failure or conditions. So in this way, we are ausculted the different areas of pulmonary area, aortic areas, tricuspid areas, and mitral areas. Here it is given in details, but you need not know initially as a beginner of this. You will see first heart sound, second heart sound. You will auscultate in the second space on the left side pulmonary area, second space on the right side aortic area, and see whether A2 or P2 is accentuated. That's all. And you can also note the split. Then this is the auscultation. So this is the examination of the heart proper, but also it is a cardiovascular system. You have to examine the peripheral vessels. So you have to examine the root of the neck for any murmur. You put your stethoscope over the root of the neck or any bruit, or sometimes in interscapular region you may find some bruit, particularly in coarctation of the aorta. Sometimes in femoral artery a bruit or pistol shot sound can be heard, particularly in aortic regurgitation, and some capillary pulsation can also be found. So these are the examination of the peripheral vessels, and you have to examine the peripheral vessels for other palpable pulses, comparison other pulses, atherosclerosis is present or not, like this. So this is examination of the cardiovascular system. Then you have to examine the other relevant systems in a case. The respiratory system, here details is not necessary, just you see chest expansion, tracheal position, apex beat, percussion note, breath sounds and edge sounds. You see liver, spleen or ascites is present or not. See jerks, plantar response, like this. So after doing a complete all this is a cardiovascular case, you will have a summary of the case. As for instance, a patient aged 28 years, female, non-diabetic, non-hypertensive, coming from such and such area, is presented to you with the chief complaints of occasional palpitation or breathlessness, like this. She gives history of sore throat in her childhood, and following that she had associated with pain of the joints, from one joint to other joints, like this. So this way you will take the history and you see that this is a case of rheumatic fever in the childhood, and subsequently she has developed mitral stenosis. So the provisional diagnosis will be rheumatic, provisional diagnosis will be mitral stenosis, severe or moderate of rheumatic origin or rheumatic mitral stenosis. So this should be the provisional diagnosis. So in this way we examine the cardiovascular system and in our clinics and come to the diagnosis, and we send some investigations. We will send some echocardiography, we will send some ASO titer like this, and then ultimately when the investigations report will come, then the final diagnosis will be done, and we will start treatment. So this is the way of examination of cardiovascular system, and you know the proforma of history taking, and general examination. Then in cardiovascular examination you have to stress more on the pulse, more of the neck vessels, and examination of the precordium. Precordium is the anterior part of the chest in front of the heart. So this is called precordium. If this is the heart and this is sternum, so this part of the heart is called precordium. So examination of the precordium, bulging, depression, scar mark, pulsation present, then venous prominence, then palpation, apex beat, its position, character, left parasternal hip, then palpation over the pulmonary area, whether a palpable P2 is present, then thrill in any area of the tricuspid, aortic, mitral, pulmonary area, and whether it is systolic or diastolic or continuous, then auscultation of different areas, the heart sounds, added sounds, and the murmur. This is very good. Subsequently, when we will see cases in advanced learner, we will show how to examine the murmur, what are the points to be done, how the murmur is propagated, in which way the murmur is propagated when the sound is more prominent, and what maneuvers exaggerates the murmurs and what decreases the murmur like this. So, how to examine a murmur we will discuss in some other topic. Thank you. Good morning, students. Today we are going to take your class, E-class, from the wards. Now I am in the OPD, General Medicine. Last time I discussed how to take history and how to examine for general survey or general examination. And after that, I will go for a systemic examination. Today, I would like to talk about how to take the history of a cardiovascular case and what are the symptoms of cardiovascular disease and how to examine what is the pro forma or scheme of cardiovascular examination. Before going to this scheme, we have got one patient in OPD who is telling the symptoms of cardiovascular disease, one of the most important symptoms, and that is I would like to record. As you know, the common symptoms of cardiovascular disease is breathlessness or dyspnea, difficulty in breathing. The other symptoms is palpitation, that means increased heart rate, and third symptoms is your syncopal attack like this, and there may be edema or swelling of the legs. These are the four major symptoms of cardiovascular disease. Now let us see what symptoms this patient is giving today. মা আপনার নাম কি? সাবেরা বিবি। কোথায় বাড়ি? রাজিতপুর। তো আপনি আজকে এখানে এসেছেন, কি কষ্ট আপনার? বুক ধরফর করছে। কতদিন ধরে বুক ধরফর করে? এক মাসের মতো হচ্ছে। আচ্ছা, এই বুক ধরফর, বাহ, ভেরি গুড। তাহলে এক মাসের মধ্যে বুক ধরফর করছে, 2-3 দিন ধরে খুবই বেশি হচ্ছে। তো এত বেশি হচ্ছে যে আপনাকে ডাক্তারের কাছে আসতে হলো। আগে কখনো ডাক্তারের কাছে আসেননি? আচ্ছা, আপনি কি কখনো লক্ষ্য করেছেন যে এই বুক ধরফরিটা কিসের জন্য হয়, কিভাবে হয়? সেরকম কিছু লক্ষ্য করেননি। খুব ঘাম হয় তখন বুক ধরফরি করার জন্য। বেশ। আর বুকে কোনো ব্যথা হয়? চিনচিন করে ব্যথা হয়। কোন জায়গাটায় ব্যথা হয়? এই সাইডটাতে ব্যথা। বাঁ দিকে কোনো ব্যথা হয় না। যখন চলাফেরা করেন তখন বুক ধরফর করে? কাজ করলে বেশি বুক ধরফর করে, কিন্তু বসে থাকলে করে না। আপনার রাত্রে ঘুম কেমন হয়? ঘুম ঠিক হয়। আপনার কোনো থাইরয়েডের অসুখ আছে কি? তার জন্য কোনো সেরকম কোনো টেস্ট করা হয়নি। আচ্ছা, সো she is saying that she has got palpitation for 1 month and palpitation has been aggravated for 3 to 4 days. That's why she has come to OPD. So the chief complaint is palpitation for 1 month, and the mode of onset, this palpitation started all of a sudden and it is gradually increasing, and for 2 to 3 days it is more severe. So we will have to examine the patient as a general survey, and then we will have to examine the patients for the cause of palpitation. But as I have not yet shown you how to examine the cardiovascular system, let us take the history and take the what the patient has told you, and I would like to see one point. আপনি আমার গলাটা একবার দেখান তো মা, খুলুন, ঢোক গিলুন, ছবিটা নাও। So the most common cause is thyroid hyperthyroidism or thyrotoxicosis. That's why we are looking at the neck whether there is a goiter or swelling is present or not. Then I will take the pulse rate. I am examining the pulse first. To cut our story short and in the OPD, just I am going straight to the pulse. In pulse examination, we will see the rate, the volume, the rhythm, comparison with other pulses and the characteristics. $90 per minute. So pulse is 90 per minute regular, and in comparison of both the radial pulse, it is okay. Character is normal, and there is no radial delay. We should also see a radiofemoral delay or not. So most likely it could be a paroxysmal palpitation, or it may be sinus tachycardia like this. So one symptoms of heart disease, palpitation, you have heard from the patient. So to continue, another patient has come. So we are talking of what are the symptoms of the cardiovascular system. We have discussed one symptoms is palpitation, and we have talked that other symptoms is breathlessness and chest pain and syncopal attack. So chest pain is a very important symptoms. If chest pain is over the precordium and it has got some characteristic of heart disease, that is, it is radiated to the left arm or to the neck or to the back or teeth, and it is brought on by exertion and relieved by taking rest or some nitroglycerin tablets. So it could be characteristics of stable angina, chest pain. So while evaluating a chest pain, whether it is cardiac or non-cardiac is very important. Sometimes non-cardiac chest pain may mimic cardiac chest pain, particularly in females and younger females. There are structures in the chest and the precordium. There may be pleura, there is lungs, there is ribs, musculoskeletal pain, all like this, and pericardium. So chest pain may arise from any of the structures. It could be musculoskeletal, it could be due to pleurisy, it could be due to pneumonia, due to pneumothorax, or pericarditis and ischemic heart disease, myocardial infarction like that. So we have to exclude, and sometimes it is due to reflux esophagitis. So we have to differentiate whether it is a cardiac chest pain and non-cardiac chest pain, and we will have to find out whether the characteristic chest pain of cardiac is present or not. Let us see in this patient of 35 years old lady. আচ্ছা মা, আপনি এখানে এসেছেন, কি কষ্ট আপনার?
ওই তো আমার জানে খুব কষ্ট হচ্ছে, বুক ধড়ফড় করছে, তারপরে বুকে মাঝে মাঝে পেন হচ্ছে, হাত পা।
আচ্ছা, বুকে পেন হচ্ছে, বুকের কোন জায়গায় পেন হচ্ছে?
বুকের এই জায়গায়, কখন এই জায়গায় হচ্ছে, কখন এই লিভারে হচ্ছে, যেন খেলে দমের কষ্ট হচ্ছে, যেন জাম হয়ে আছে।
জাম হয়ে আসে। তো এই যে জামটা হয়ে যায় সেটা কতক্ষণ থাকে?
অনেকক্ষণ থাকে, মনে হচ্ছে ওষুধটা খেলে খানিকক্ষণ পরে একটু কমে।
কি ওষুধ খান?
ওই যে ওষুধ দিয়েছি,
সেই ওষুধগুলো খেলে পরে কমে। আচ্ছা, এই পেনটা যে হচ্ছে আপনার বসে থাকা অবস্থায় বেশি হয় না চলাফেরা করা?
বসে থাকা অবস্থায়, এমনি যে বসে নিজেই কাজ করলে তখন একদম ওঠার ক্ষমতা থাকে না।
আচ্ছা, এই পেনটা কোথাও ছড়িয়ে যায়?
হ্যাঁ, মাঝে মাঝে ছড়িয়ে যায়।
কোন দিকে?
চলা করলে এই সাইডে চলে আসে, কোন সময় এখানটাই হয় এইরকম।
So she says that she has got pain over the precordium, but it is not typically radiated. And one thing I have noticed, and whenever I asked her where is the pain, she pointed out that here it is, or sometimes here it is. This is against the cardiac chest pain, and sometimes the ladies approaching towards 40 may have some anxiety chest pain. So this is most likely a non-cardiac chest pain. I will show you a cardiac chest pain whenever we will confront it with. Thank you. Okay, let us continue. So this is a patient, and we would like to go for examination of the cardiovascular system. The cardiovascular system examination comprises of examination of the pulse, examination of the neck veins, and examination of the precordium. Previously, we have talking of the history and what are the symptoms of the cardiovascular system, but now we have come for examination of the cardiovascular system. So, in general survey, we have noted the pulse, what is regular or characteristics of the pulse, like that. But more details examination of the pulse is necessary here. So, how to examine the pulse I am showing you. You see, this is the radial artery. You can feel the pulse with 3 fingers, and you see the volume of the pulse, the rate of the pulse, and any characteristic of the pulse, whether it is irregular, whether it is regularly irregular, or irregularly irregular, like that. Then you may sometimes take the chances of whether patient has got water hammer pulse or not. You place your hand here in the radial artery and suddenly raise the hand. If it is increased, it is most likely to be hyperdynamic circulation and sometimes characteristics of water hammer pulse, which is found in aortic regurgitation. Then we will have to compare the other pulses. I am taking the pulses of both the hands. Then we may take the pulse of the dorsal spadius, the femoral artery pulsation, and we note any radiofemoral delay or not. And in sometimes a very rare condition of coarctation of the aorta, will have a radiofemoral delay. So this is the pulse, or the rate of the pulse, or the regularity, characteristic, and comparison volume of the pulse, comparison with the other pulses. Then we will see the neck veins. Mostly the right internal jugular vein is seen, but here it is not very prominent. This internal jugular vein is lying under the sternomastoid muscle. Sometimes the external jugular vein becomes prominent. It is more superficial, more sinuous. But in our purpose of jugular vein, we have to look into the internal jugular vein. We have to see where the height of pulsation, and from the height of pulsation we have to draw a straight line, and from the sternal angle we have to draw a straight line, and both this line where it joins, that is the centimeter is the jugular venous pressure. The right, it is a measure of indirect measure of right atrial pressure. Normally right atrial pressure equal to the 5 centimeter, and it is in so 9 centimeter is the total. If you distract this 5 centimeter, that would be the pressure of the jugular venous pressure. I will talk on this subject with definite jugular venous increased cases, and when we will be attending this clinic, it is a very difficult to understand from these online classes, but you see the jugular venous distension and waveforms. The two things you have to note: distension and waveforms. There are 3 positive waves, A, C, V, and 2 descents, X and Y descents, of which most important find out the A wave. So sometimes the A wave may be very large. We call it cannon wave. It is found in heart block, and sometimes you can see other sinuous waves, X descent or Y descent, pericardial effusion and tamponade like that. So pulse, then jugular venous pressure. Then we'll have to examine the precordium. Precordium is a part of the chest in front of the heart. This is the normal anatomy of the heart, like this. So it is inside, apex is inside the nipple in the fifth intercostal space in the mid-clavicular nerve, and this is the base. So this is the normal anatomy of the heart. So this part of the chest in front of the heart, we call it precordium. We have to see inspection, palpation, and other form percussion is not done, and auscultation in the examination of the precordium. So first thing, in the inspection of the precordium, we to see whether any skeletal abnormality. You see, sometimes there may be indentation or dipping in the precordium. Then sometimes it may be raised. There is sometimes some skeletal deformity, scoliosis. There may be some scar marks of operation. So there may be some sternal operation, sternal incision in case of CABG like that. There may be here or here there may be some implantation of pacemakers. So all these scars are to be noted. So with deformity of the chest and any scar mark is present is important. Then we have to see the pulsation. There are certain areas. We call it mitral area. This is the mitral area. This is the tricuspid area. This is the pulmonary area. This is the aortic area. The right second intercostal space close to the sternum is the aortic area. Just like on the left side, this is the pulmonary area. This is the base of the heart. This is the tricuspid area, and this is the mitral area. So any pulsations on that areas are to be noted. Sometimes we have to note also the pulsation over the epigastrium or not, and the pulsation of the carotid vessels. And in the carotid vessels, there may be pulsation venous or carotid artery. So you have to differentiate whether it is a venous pulsation or arterial pulsation. In arterial pulsation, it is jerky and outwards. It is one time, but venous pulsation is a sinuous. It is both two peaks. So venous pulsation, it is distance. It can be stopped by pressing pressure over the root of the neck, but carotid pulsation not. In this way, we have to differentiate whether it is a carotid pulsation or arterial pulsation or venous pulsation. So inspection, the scar marks, the pulsation. Then we have to go for the palpation of the heart. The palpation means we have to find out the apex beat. In inspection also, if there is any pulsation over the apex, that could be the apex beat, but that should be corroborated on palpation. On palpation, you have to find out by your palm of the hand. Just place your hand here and turn the patient to the left lateral position. And if you have a pulsation, then locate it by means of your fingers. The outmost and downmost definite impulse is the apical impulse. This is now the apical impulse. This is a normal patient. This is the apical impulse. So you have to count the ribs and the fifth intercostal space on the mid-clavicular line. So it is in a normal space. Then you place your hand over the tricuspid area like this, whether it is pulsation present or not. Then on the pulmonary area and the aortic area, the root of the nose. And not only along the pulsation, there may be some left parasternal heave also in ventricular hypertrophy. So pulsation and thrill is the palpable part of the murmur that can be also felt under the hand. These are all not theoretical, practical aspects that should be felt by yourself. So I am just narrating here to show an outline or a just nutshell overview of how to examine the heart. Then after doing the palpation, we have to go for auscultation of the heart. There are 4 heart sounds, so we have to hear the heart sounds. First heart sound and second heart sound is common. First heart sound is lub, second heart sound is dup, lub, dup. There is a gap between the first and second heart sound. We call it a systole. And there is a gap between the second heart sound and first heart sound, and we call it diastole. So first we have to listen carefully to the first sound, whether it is first heart sound or second heart sound. This is very, very important. First heart sound is broad, lub. Second heart sound is short and split, droop. Sometimes it may it becomes very difficult, then you can put your finger over the carotid artery and put the stethoscope here, and which when the sound coincides with this carotid artery, there is a first heart sound, and then the gap is systole, and then the second heart sound. Then whenever by practicing the first and second heart sound, you will be able to practice other sounds like opening snap and the third heart sound, fourth heart sound. I am not talking right now. Then put your stethoscope over here in the tricuspid area, in the pulmonary area, and in the pulmonary area you will listen to the most importantly the second heart sound. The second heart sound has got two components, aortic component and the pulmonary component. It is due to closure of the aortic and pulmonary valves. So there is a gap between these two, A2 and P2, and this gap varies with inspiration. So it is a variable gap with inspiration. Ask the patient to take deep breath and the gap widens. So this is to be practiced, whether there is second heart sound, whether the gap is increasing during inspiration or not. In some pathological condition, you may get this gap is wide. We call it wide fixed gap of the second sound, and the diagnosis is atrial septal defect. Similarly, the component of the second sounds A2 and P2, whether it is accentuated or it is diminished, that should be also noted. Similarly, you have to place stethoscope here in the aortic area. And if there is any added sound, we call it murmur. It's a musical sounds or different kinds of sounds between these heart sounds. If it is found, we have to advance the stethoscope along the propagation of the murmur. If a murmur is systolic and it is propagated towards the axilla, pansystolic is a murmur of mitral regurgitation. Similarly, if a murmur is a systolic, diamond shaped, and which is radiated to the over the carotid, is a murmur of aortic stenosis. Similarly, if there is here, it is a murmur of pulmonary stenosis like this. A characteristic type of murmur is found in mitral stenosis, which is low-pitched, rumbling, mid-diastolic murmur, best heard by turning the patient to the left lateral side and with the bill of the stethoscope. I will show all these patients with the murmur in your ward when you will be available. We will come to the ward for further clinical exercises in the next semester. So this is in a nutshell, and before ending, we have to see the basal crepes on the lungs. So whether there is capitation bilateral or not, that should be seen. So this is in a nutshell the examination of the heart.